Let me know if you can share. You were able to, right?
Yes.
Good morning, everyone. Thanks for joining us. Sorry about the late start. We were having some tech issues. But today we have the second webinar in our June series, and we have Joshua Leslie back again with us. So I'm going to hand it over to him so he can go ahead and get started.
Hey guys, good morning. Yes, part two. So for the kind of the second installment here, we're going to be talking a little bit about Suboxone best practices. And the reason that we kind of jump right into Suboxone is that from a PCP perspective, family medicine perspective, when we're looking at substance use disorder services and treatments, usually the medications that we're using are, and we talked a little bit about last series as well, we obviously get into the naloxone side or the antidote side, and we want to make sure every patient using opioids, no matter what, has that. And then we talked a little bit about naltrexone, which is it's actually a true blocker of opioids themselves. This we're going to take some time today to talk about Suboxone, which is a partial agonist. It is, and we'll talk about it here in more detail, but it is really one of the best options we have in the treatment for opioid use disorder. And then again, on the PCP side, there's not going to be jumping into methadone. If the patient is at that point, we're going to be looking at sending to an opioid treatment program or an OTP. So we'll go ahead and get started this morning. All right, so kind of the overall agenda today, we're going to give a brief overview, really 3 core phases regarding the treatment with Suboxone, and we'll talk about those in more details, looking at different strategies. And then again, I'm really open for question and discussion. I try to keep PowerPoints fairly brief and open the line for further engagement, for the dialogue. So we'll just kind of hop in at this point. The biggest thing that we're focused on here is looking to try to find effective ways to manage and aid patients who are either requesting treatment for opioid use disorder or have been identified as suffering from opioid use disorder and in need of some form of treatment. Kind of the next point that I want to bring up, and this is really one of the most, if not the most important points of the entire presentation, is that if somebody comes in and they are looking for or interested in or requesting treatment for opioid use disorder, we have a tiny, small, itty-bitty window to work with those patients in. There's a moment of clarity. And so really, when we're putting programs together, we're putting resources together, kind of demands that those resources are available the second somebody comes in, that same day type of service line. You know, for us, like working in psychiatry and substance use disorder, this is our like code blue, right? Or code red, or, you know, emergency crisis type situation where we got to get that patient in right away if they say that they're open and willing to get some help. And so we're going to talk about various strategies on how to engage those patients in that care. And we're going to talk about, how and what services are out there and are available. I want to just kind of caveat this with, I'm fully aware that not every practice is going to have all of the resources in place. This in the first lecture talked about this as well. We look at harm reduction. We look at patient-centered approach. We look at what resources we have or we don't have. We try to develop those resources if we can. But again, we want to at least push and attempt to provide the best possible resources that are out there, or partner with organizations that have maybe some of the resources maybe your organization does not. So with Suboxone, so again, we're going to be talking about Suboxone today. So with Suboxone, there's 3 primary stages of treatment. The first stage is the induction phase. And the induction phase is really that first week that a patient comes in seeking help. We're working really diligently to transition that individual from opioids over to Suboxone. There's a lot of engagement during that time because this is where, I've given similar lectures like this before, and this is where I use my drug dealer reference. And it's really, really true. And I've actually working with patients, working with other organizations, this is what I want there to be some understanding of. That when somebody comes in for treatment, there is a battle that occurs. And I truly mean battle that is occurring. So this battle occurs that we're going to look at services, we're going to look at medication, we're going to look at the medical side of treatment, or we're going to be looking at going back to previous ways, which a lot of times is working with a drug dealer, right? Working with someone that's providing that substance to those individuals. So there is a battle between the medical provider and the drug dealer. And historically, these battles don't go very well. Drug dealer, they're available 24/7. They're going to make sure you're feeling good at any point in time, as long as you've got access to cash, services, whatever it may be, right? So drug dealer, always on call, always available. Suboxone provider, they put a 30 patient caseload maximum, so not always available. Clinic hours, right? Monday through Friday, not really available, right? After hours work, probably not an option. So there is a battle that is occurring. So we have to do the best. And that first phase, that week 1, is so important. We have to do everything we possibly can to win that battle, to get that patient over to the medical side of things, over into the medication supported treatment side of things. And so this is that phase 1, and I'll talk about that in more detail here briefly. We can get somebody over to that side, that phase 1 induction side, and we can get them through that initial withdrawal. Then we're looking at the stabilization phase. And during that phase, that's usually the next 2 to 3 to 14 weeks, you're looking at monitoring the patient, you're curating, you're stabilizing that patient, you're looking at the clinical response, you're engaging that individual, whether it's in withdrawals or stability or relapse prevention, all of those areas. And then we get through those next 2 months or so, and then you start getting into your maintenance phase. Now, all of these phases can have different variations of time. This is just, again, for some general education. And in that maintenance phase, that's where your patient's done fairly well on Suboxone. There could have been some relapses, there could have been some things that occur, but at this point, they're doing fairly well. They've completed a lot of the treatment engagement that you've created, and that they're really ready to maintain, to continue on their day-to-day. And we'll talk more about that in detail as well. So again, first step is the induction phase. Really important. The goal of the induction phase is to find the appropriate dose of Suboxone for each individual patient. I say appropriate dose because there's a lot of variance, and this, in my opinion, on the PCP side, is often the biggest challenge. The first thing I always do, I'll just tell you from a clinician perspective, first thing I do when I have a patient comes in and is interested in Suboxone, I ask them straight up, how much Suboxone have you been on in the past? I don't ask, have you ever taken Suboxone before? Because there is stigma. There is scenarios of, well, I probably shouldn't have taken Suboxone, but somebody gave it to me, or somebody, I got it from someone, right? I remove all of that. And I just ask, what dose of Suboxone have you taken before? A lot of patients. I don't have a specific percent, but a lot of patients have been on on Suboxone in the past, they've gotten it from somebody. It's great to stave off those withdrawal symptoms, right? So they're going to tell you like, hey, I was taking 12 milligrams, or I was taking 16, or I was taking 4s. They will tell you, and you want to work with them on this, right? So we all want to work together to find what that good dose is. We want to, very importantly, discontinue or diminish all of the use of opioids with no horrible withdrawal symptoms, right? Because those withdrawal symptoms are actually what brings somebody back over, again, that battle to the drug dealer, right? So if you, as a clinician, give low dose Suboxone that isn't having any effect, they're in active withdrawals, they're continuing active withdrawal, you're going to lose that battle every time. So it's really important that we do work with the dosing and that we find the dose that's effective to reduce or limit the amount of withdrawal that a patient's experiencing. We're trying to minimize or reduce any side effect. And we're also working to try to control some of those cravings. So there's that physical craving side, that's what we're working to control. There's also going to be like that psychological dependence side, and that's going to be worked on through resources, through additional services, hopefully being provided to the patient. But again, that may not see as much of a benefit with Suboxone on that side of it. As a general rule, you should always caution patients anytime that they're starting a new medication. Again, I put that in here as like a disclaimer slide, but patients are using opioids. So we already know that they have some type of opioid in their system, or that they're having some daily tasks diminished or executive function diminished already. But again, we always say, hey, this is potentially a new medication. Make sure that you're cautious while driving, operating machinery, those types of things. And then also some education with patients around the different type of opioids that they're taking and whether they're short acting or long acting, which can affect when we're able to start the induction itself. So, there's a couple of kind of key points, key elements. Again, more than willing to share these slides with you guys from an education perspective. The first thing, and really the tried and true method here, is that we always want to evaluate the current withdrawal symptoms. And so, you just heard me in the last slide say, hey, the focus here is to avoid withdrawal, right? Limit the withdrawal. It's the battle, right? Battle between drug dealer and provider, right? In order to start Suboxone, the patient does actually have to start in some level of withdrawal. Otherwise, because of how Suboxone is formulated, it can actually create or cause something called precipitated withdrawal. And so we do want to see the patients in some level of withdrawal. And that is done through your clinical opioid withdrawal scale, or CALD scale. And then again, talking to that patient, are they short acting opioids? Is this heroin, right? Is this Vicodin, right? And then if it is, you're going to start seeing and feeling those withdrawal symptoms in that 12-hour to 24-hour mark. And then, is this a long acting opioid? Is this your fentanyl patients, right? Those types of individuals, it may take longer, right? 24 to even 36 hours before you start induction, because it's such a long acting opioid that's in their system. And then again, looking at kind of two different scenarios. You have spontaneous withdrawal. And so, the patient comes in, they're working with you. Hey, we found our window. We meet that patient day one. And, they say, my last use was 16 hours ago. I'm really struggling here. Can you help me out? Absolutely. Let's get you started in treatment. Let's get going. And if we start very low or too low with the Suboxone dose, they'll continue to go into their spontaneous withdrawal. The withdrawals will continue. And really, when that occurs, we're using too low of a dose. We need to increase the dose of Suboxone. And then we can pair that with some non-opioid medications, things like Zofran, Bentyl, stuff like that, things that'll just kind of clonidine, things that'll help kind of resolve some of those symptoms they're experiencing. And then on the flip side, if they maybe aren't in full active withdrawal and we start the Suboxone too soon, we actually create precipitated withdrawal, where we really intensify the withdrawal, and it happens fairly quickly. And that's in that first 30 minutes to an hour after taking the first Suboxone dose. And they're like, what is going on? But you see, if as a clinician, once you see precipitated withdrawal, you know it, and you see it once, you got it. And it does, it hits quick, and it's, hey, what happened here? Now I'm really struggling. And the response is actually to provide more Suboxone. And so it's not an area to necessarily panic, but it is something we need to be aware of. We actually add more Suboxone, and then again, pairing that with some non-opioid medication relief of symptoms. Again, that Zofran, that benzoyl, those types of things. And so, really trying to nail this down and trying to talk to providers about how it works. What are next steps? Patient shows up day one. What should I be looking at? Every case is individually dependent. And so it's you as the clinician deciding, working with the patient, but best practice or rule of thumb or what we can at least, give a general idea here is that patient comes in, they've got to have a CALS rating score of at least 6 or more, should be a little bit higher. And they're showing some active withdrawal, and that we get started. So we'll initiate, again, we'll talk in home and office, right? We talk kind of both sides of this. If you're doing it in office, obviously there's direct observation. It does make it a little bit easier, but there's a lot of in-home inductions occurring right now. Like my company, we do actually 100% in-home inductions at this point. But what you do or what you educate your patient on. So if it's in office, I'm observing them. If it's in home, I'm educating. Right. So we say, okay, start, somewhere between 2 and 4 milligrams of Suboxone. You want to give that first. You want to make sure, again, no side effects, no issues, and things like that. You're going to observe that for about 30 minutes to an hour. You can tell the patient, take, a 2 or 4 milligram, give it an hour, and then see how you're feeling. And we actually give the patient and show them like, hey, here's the CALS rating score. You can even rate yourself. You can't rate yourself completely, but you can at least get a general idea of where you're at. And then we say, okay, if it's at home, we give dosing up to 8 milligrams day one. And say, all right, you took your 4, see how you're feeling. If withdrawal symptoms have subsided, cravings are down, you're feeling okay, great, keep it at the 4 as long as you can. And then if you need another 4 milligram dose, it's available to you. So about the max is about 8 milligrams a day. I can tell you, I've worked in OTPs, methadone clinics using Suboxone in those OTPs. And, there are times we do have to go a little bit over the 8 milligrams, but that is considered the standard or what's considered standard day one. Next, induction phase, day 2, we really want to get that patient back day 2. First thing I always ask my patients on day 2, how are you feeling last night? Start to tell you a little bit, this is this, and I say, well, what'd you have for dinner? Standard question I always ask. If they can tell me that they ate food at 6, 7, 8 o'clock at night for dinner, that means that you managed their withdrawal symptoms to a decent extent. If they're holding food down, it means that you're getting close to the right dose. You're managing things fairly well. If on day 2 I said, what'd you have for dinner? And they say, well, geez, Josh, I didn't have anything. All I did, I was throwing up all night. Okay, we got a problem. Like we didn't get that dose right yet. We're not there yet. So then on day 2, we're looking at those symptoms, looking at cravings. We're able to at home do another CALS score. If you're in office, for sure, do another CALS rating score. And then you're going to increase that dose. You can go 4 to 8 milligrams, somewhere in that range. And again, usually we're hitting, if we need to, about that 16 milligram dose by day 2. And then day 3 comes. And then by day 3, we're hoping again, similar questions, right? What did you have for dinner? How did you do last night? Any cravings? Did you call your drug dealer? Like, do you call your support systems? Like, where are we at? And then we can adjust accordingly. I'll tell you, a lot of folks that I've worked with over the years, by day 2, we're already stable. Day 3, that 12 to 16 milligram dose, we're good. We can push doses further if we need to on day 3. Again, 4 to 8 milligrams. Really don't want to be above about 20 milligrams at day 3, if at all possible. And then day 4 and beyond, meaning that first week, we really want to continue to work with the patient, engage with the patient, do the CALS score, see where we're at, see what's happening. We can push upwards of 24 milligrams a day. But if we go if we're not holding at 24, typically there are some areas, and we'll talk about this, you're starting to look at referrals into like an OTP program, and Suboxone may not be the right medication for the patient. So what does it look like as a clinician? So what does it look like for your team? What does it look like for the office, right? When a patient comes in looking and seeking this resource. Majority of these inductions, if possible in office, it's great. You have your NAs, you got nursing staff, you have the ability to monitor it, you got your providers there, you can monitor it, and that's great. But, as I said earlier, I own a telemedicine company, and, again, 99% of our work is all virtual, and we've been doing inductions in home for years now. Very successful. We also have additional resources that are checking in on those patients during that time as well. But the virtual landscape for inductions is very common at this time. Frequency of contact is determined at the practice level. So it is between the clinician and the patient and the resources that you have available. So if you are, like a single practice provider, or maybe you have some providers in the practice, but maybe you don't have, your licensed, independent licensed substance abuse counselor, and maybe your program doesn't have peer support yet, and maybe you don't have those things in place. Well, then your decision is probably you're going to check on that patient a little bit more frequently from the medical provider side. So maybe you're going to see that patient a couple of times that first week, even if it's, a 5-minute slot that you're sliding them in between some other patients. That first week is just so crucial, and you've got to you have to become sticky. You got to get that patient to stick with you because it is a hard period of time. They're really struggling during that time. They're struggling with the physical withdrawal side of things. Psychological withdrawal is coming. And the psychological side of this is coming, but that physical is really intense that first week. And so, again, if you don't have those resources, maybe you as a provider have to say, hey, I got to be available. I got to make myself available, 3 times in those first 7 days. It's a decision at the practice level, but the more engagement you can provide that first week, the better. And then again, if you're a program that's developing and building, that first week of contact, you want that therapy engagement, you want recovery support, you want case management, you want to find out what's going on, what social determinants of health can we resolve or can we assist with, so that we're hitting the treatment from multiple approaches all at the same time if we can. We want that patient to feel completely wrapped up in care, and that there are individuals that care. There are individuals that are trying to do everything they can to get that patient through that first week, and then obviously further on for stabilization. One of the areas that have to be discussed, especially during induction phase, is relapse. Induction is very difficult. That phase, like I said, it's acute. It's physically ill. There's still a lot of direct contacts with their former or their current, say, support systems, or maybe bad support systems, right? The drug dealers, there are other individuals that are using or have been using with them. There's a lot of things pulling a patient back into relapse. And so that's a real thing. And so it is a discussion that needs to have, right, with that patient. What are your social supports? Where are we going with this? If you have relapsed, are you able to do this in a home environment, in an office-based environment? We need to look at a higher level of care. We need to set up with like an OTP service provider, like a methadone service provider. We've got to consider all of those options. And if a patient says, yeah, you know what, I don't know where I'm at with this, but I want to make this work, right? Like, we got to make this happen. And then you say, okay, I've got a therapist, I've got this peer support group, I've got this network of services. Let's get all these things in place, and then we can consider another induction with you. Totally 100% makes sense, right? If a patient says, I don't want to do that, I don't want to do this, I'm not interested in that, just, basically just hand me the pill, we'll try it again. You really, really want to emphasize, like, hey, this is probably going to be another higher level of care situation. This is what's really best for you, and you want to provide that level of support. Do everything that you can to engage and to kind of get those patients into that higher level of care. And you may say as a clinician, okay, all right, second time, right? We're going to try this one more time here with you, but you gotta really focus. Maybe we try another induction with them. And we say, okay, we tried another induction, here's where we're at. And maybe that time it works, it's great, but we are always pushing a higher level of care. There is a point where, and maybe that's your second time, maybe that's your third attempt, but have a conversation with the patient since you're not in the place where you're able to provide that service to them. Because going, on and off of opioids and flipping to Suboxone, that has its own risks as well. And so these are all decisions that are made at the practice level with the clinical team. But again, it is something that will occur. If you're providing this resource, guarantee you're going to have patients at relapse and that you're going to want to try to work with them through that. And it's the highest probability occurs in the induction phase, right? And then the maintenance phase, or excuse me, the stabilization phase is the next highest, right? And then the maintenance phase is kind of the last where you see relapse occur. But it can occur all throughout that cycle. It's just at the highest percentage during the induction phase itself. All right, so that's your induction. So if you have got that patient in, you got them seen, you got them taken care of, got them through week one, now what? Like, now what do you do? Again, trying to talk with groups that have resources, maybe don't have resources, looking at building that. This is where, if you don't have resources, you got to try to start finding and working with some community partners. You got to try to get some outreach there. You got to try to bring some services internally. Do what you can. But that stabilization phase really starts hitting the psychological side of dependence. And we need to provide support. We need to provide engagement with that individual. We need to normalize what they're going through and having those resources there to support it. And so this is where the work occurs, right? The work around addiction, around dependence of opioids, the more intensive therapy, the more intensive peer support efforts. And this is usually occurring for the first 1 to 2 months. Now, on the Suboxone side, or the buprenorphine side, most patients are going to stabilize, again, 8 to 16. I'd say in my clinical, 12 to 16 was usually the average range. Some patients push to 20, handful of patients pushing to 24 milligrams, but it's pretty rare. And then honestly, most studies are showing that anything over 24 milligrams, you're just really hitting more side effects. You're not saturating that opioid receptor or the partial agonist receptor side to a point where they're actually getting any more benefit. And so at that point in time, if we're pushing beyond that and there's no response being received, that's where we start looking at, a couple of different things. One, could they be a rapid metabolizer of Suboxone? Maybe. Two, are they diverting the Suboxone? Right? Are they distributing it? Are they handing out to other folks, or this or that? Those are things that we can look at through drug screens, right? And we can see what's going on. And then, or three, is it just that, honestly, that their opioid use has been so potent, so strong for so long that they kind of fried those receptors, and that the Suboxone just isn't going to cut it? And then we do have to look at that next level, which is, the methadone, the OTP programs. During this phase, we're definitely going to want to do CAL scores. CALs are going to show us what the actual withdrawals may or may not look like. We want to see those CAL scores very low, 0s to 1s, 2s at the max, making sure that, again, our dose is removing withdrawal, not trying to get any, there's no reason to have anybody intoxicated on Suboxone, but we're looking at removing the withdrawal side of it and working with our other resources to reduce some of the physiological and the psychological dependence side of it. And so then what does contact look like during that stabilization phase? Again, this is where we emphasize the support services, IOP programs, really strong peer support, individual counseling sessions, group counseling sessions, and then also, from the medical provider side, or like the data waiver of medical practitioner side, those first couple of weeks, usually weeks at least 3 through 6, you're going to want to see them once a week. Weeks 7 through 14, you may push out to every other week. I usually do about 10 days to 14 days on follow-up. And then weeks, 14 and beyond, if they've been established in some of those other resources, you start looking at that maintenance side of things. But again, this is all variable based off of like the clinician, based off the organization, based off the resources that you have. If you don't have the resources, maybe as the medical provider, maybe you're seeing that patient every week, right? And you're doing that from weeks 3 through 10, or weeks 3 through even 14, because you need to have those clinical engagements continue to occur while you're working with external vendors to try to provide more support. So again, I know it's all variable based off the facility, based off the individual clinician, based off resources that are available to you. If we do get through that maintenance, or excuse me, through that stabilization phase, and we're making good progress, and actually one of the things I didn't put in here, relapse. So relapse during stabilization phase, pretty simple. If there's a relapse during stabilization phase, or if they stop Suboxone, typically longer than 4 or 5 days, and usually that's indicative of a relapse, we got to go back to the induction phase. So, I know that can be kind of heartbreaking and difficult for the patient, but at the same time, it's like, okay, we go back to the induction phase because we want to make sure everything's like safe and we're managing and making sure there's nothing that we didn't miss. And then we talk about, that again, that higher level of care. All right, we tried stabilization, we got through week 5, but then there was a relapse. All right, let's get you through the induction phase again. Let's keep things close. And now maybe we need that more higher level of care. Maybe let's look at an IOP program. Maybe let's add in an additional layer of peer support, like those types of things, right? And then we're just monitoring during that time. And again, so they make it through stabilization. Now we look at maintenance. So that maintenance phase, really, we should have well established a therapeutic dose of Suboxone. And if you guys kind of, again, take note, that stabilization dose is typically, honestly, done within the first couple of days. I will say that I have a handful of patients that would last longer than a week or two into the or past the induction phase where we were still adjusting doses. Usually that Suboxone dose is pretty locked in pretty quickly. And most are locked in within about 3 to 4 days. So again, completed, doses are steady, they went through the stabilization phase, they're really engaging in their activities of daily life, they're doing everything, working full time, doing their thing, handling and managing psychosocial stressors, hopefully with either your team or external resources that you provided them, and that you are able to start to have more discussions around, how much direct clinical engagement is needed. I would say for like the medication provider side, these are things where we're not making a lot of dose adjustments. There should not be a lot of discussion around withdrawal symptoms at that point. You're checking in with them, once a month, how you doing? But again, we do always discuss that if a patient is starting to say, well, I'm having more withdrawals, I don't know what's going on. We typically at that point are looking at a couple of things. The first is the diversion of medication. If I'm writing you for 16 milligrams Suboxone a day, and you've been stable for 12 to 13 weeks, and then you start saying, hey, I'm having a lot more withdrawals, I'm doing CALs, and the CALs are actually showing, the CAL score showing that you are in withdrawal. First thing that we're asking is like, well, wait a second, it doesn't line up, it doesn't match up. And it's like, who else in your support system is using right now, right? And how much are you helping them? Like, those are the discussions that I have with the patient. And they kind of look at me like, what are you talking about? It's like, well, I'm assuming you're helping somebody. You've been stable for months now. Are you maybe handing over, half that dose to somebody to try to help them out? Let's get them in treatment. Our doors are wide open. Let's help them out. Why is there diversion occurring? And a lot of times that is an opportunity not to be in trouble from a patient perspective. It's an opportunity to engage someone else in getting resources. And I will tell you clinically, I have seen this, and I've experienced it so many times where this is exactly what occurs. Patients, starting to have symptoms of withdrawal, something's going on, find out that yes, their spouse, their significant other, their friend, one of their supports was interested in getting them the treatment, and that they didn't have insurance, or they didn't have, they didn't know the resources were out there, just the stereotypical, like I didn't want to go in, I didn't want to be judged. And so they're using someone else's Suboxone, or using your patient's Suboxone. Rather than making this huge ordeal out of it, let's, hey, that's not a good approach to care. Let's get them in, let's get them treated, let's figure this out. So, and then the last thing that can occur is some rapid metabolites medication. So it's not super common, but it can occur. And then you can do some testing too if you need to, depending on the insurance provider. You can even do like pharmacogenomic testing, which will show whether the individual is a rapid metabolizer of Suboxone or not. So those are things that we can look at. Again, what's your contact during that phase? So you as the providing the Suboxone, so the data waiver medical provider, it usually is less at this point. It's usually a monthly check-in. It's important to still check in. It's important to show that patient that you're still there, you still care. You want to make sure that they're doing okay. But it may just be once a month. You may just say, hey, how have you been? What's new? What's going on? Trying to head off things from occurring down the road. So you've had all of this intensive engagement with this patient. You kind of know a lot about them at that point. You know the ins and outs, you know what's happening. And you as that provider can really adjust this maintenance phase. Maybe it goes back to a stabilization phase, right? So maybe you're in there and you're sitting with your patient, you know, you got 15 minutes with them, and they say, yeah, just had a breakup, right? Or I'm losing my housing again. Right? And you know, because you just spent literally multiple times a week with them, you know that's a trigger, right? You know that's going to be an issue. And so you say to the patient, hey, I know that you're in this maintenance phase, but because I care, because I know what you want, because I know where you've been in the past, why don't we drop you back into that stabilization side of programming? Why don't we try to get you into some of these additional resources for the next couple of weeks, preventatively, right? Not saying that you're out of maintenance, just saying like, there's some things that are coming down the pipeline here that could expose you or increase your risk for a possible relapse. Why don't we increase your services for a little while as we're working through that? A lot of patients are very open to that. They appreciate that you know their story, you understand what's going on, that you're wanting to help them. It's always dependent, though. Again, maintenance phase is always dependent on the therapist, recovery support, case management. You guys are all working, hopefully, as a team to determine what that looks like, to determine what those next steps are. So I also have in here for the slide deck, again, anyone that's interested, again, online, you guys can find the clinical opioid withdrawal scale. You're looking at, what your pulse is, and you can teach patients how to take their own pulse, right? Are they sweating, right? So over the past half hour, and again, not accounted for like room temperature or patient activity. We're coming into the summer. When we'd always make sure that our patients, like I said, are inside at least for 15 to 20 minutes prior to asking that question. How restless are they during the assessment? Pupil size. And so, you ask your patients, they can do this, right? They're in the mirror at home, they're looking at their pupil size. The joint or the bone pain, that's one that is very, very common, and it can really show you kind of where you're at on your scale. Runny nose, watery eyes, GI upset. Again, that was the big one I was talking to you guys about with, what'd you have for dinner last night? And GI upset, that is something that's extremely common on the withdrawal side of things. Tremors, sometimes you'll see some tremors. Patients can observe that. Are they yawning during their assessment? And again, having the patients assess that they can assess their anxiety ability level, and then the goose flesh skin, looking to see where they're at on that. And then I do a lot of education with patients on precipitated withdrawal. So when we're getting a induction started, and I'll go through this with them as I'm seeing them and say, okay, let's check your pulse. We go through it all. How anxious do you feel? And the patient like instantly is like, I'm a 4, right? I'm a 4. And they start going through, are you tremoring? Yeah, look, I'm tremoring, I'm a 4. Which tell them, like, if you are over exaggerating your symptoms and you say you're in active withdrawal, but you're not, and we start this Suboxone, we do run a risk for precipitated withdrawal, which is going to make you feel really crappy really quickly. And so I really educate my patients on taking as best they can an objective approach at where their actual withdrawals are. And that does help a lot at reducing those precipitated withdrawal events from occurring. And then on the other side here, just giving a general kind of idea of medication. So one of the things I get asked a lot is take-home medication. So your facility or your resource doesn't necessarily have the ability to do in-office inductions. And so now you're talking about like take-home medications or take-home inductions and how does that work? And so this is kind of a general mindset of it. So, that induction phase, you're going to write that prescription, for about 3 days, 4 days. You're going to try to see that patient, twice a week whenever possible or more, depending on the program. And then you get into that stabilization phase. Really, I look at it as like a 2-part stabilization. So like part 1 is weeks, 3 through 6, and you're going to write a prescription usually like once a week. That's usually the standard. You're going to try to see that patient weekly. And then you're obviously going to focus on, like I said, those social, those familiar supports, You're going to really try to push weekly drug screens if you can, push that participation in that more counseling, case management, IOP type programming. And then week 7 through 12, at that point, patients done really well. Honestly, I'm usually writing scripts every 2 weeks. And that I'm trying to see them every other week. And again, it depends on resources. Like our program might come, we got a lot of resources available, but maybe yours doesn't. And so if you don't, maybe you're still weekly with that patient and you're only writing for 7-day scripts at a time. You can also work with your pharmacist. I work with a lot of the pharmacies and I say, hey, rather than all of the additional paperwork assigned to this, I'm going to write, a 4-week prescription, but the pharmacy is only going to dispense 7 days at a time. So having good relationships with your pharmacies are really important as well, because they can make this a lot easier for you. So you do not feel overburdened with administrative tasks while you're taking on this type of patient that does require a lot of involvement, a lot of engagement. So that can also be very helpful. And then again, once we get into that, week 14, 15, successfully get into that maintenance phase, we're really doing once a month prescriptions at that point. And then just doing that check-in when it comes to refill time. So a couple of last slides, and then we'll open up to some questions here. Another take-home message, really important, is patient engagement. Whether there's relapse or not, doesn't matter. Like keeping the patient engaged will deliver you the best chance for successful outcomes. And so with that, we want our patients to take an active role in their treatment. We want them to involve a larger team approach if at all possible. That's recovery support, that's therapy services, that's case management, that's a medical provider, it's everybody. So important to get that team in place, and that will allow those individuals to feel encouraged and comfortable to be an active participant in their care, whether it was a good outcome or a bad outcome. And if they're telling you, hey, I relapsed, but they're not gone, then we still have a chance and we can still get that patient back and we still get that patient engaged again. We want to individualize any possible resource they have, whether that's individual, group, family counseling, whatever it needs to be. And it's really important to put a relapse prevention plan in place, and that we want the team to be a part of that. And we want the patient to help lead that relapse prevention plan. And we want to educate that relapse is a key part to ensuring engagement throughout the treatment strategies, right? And so, these key areas of relapse prevention, like what do we change? How do we stop relapse from occurring? Or how do we prevent it from occurring? Or if it does occur, that it's relapse at a minimal level versus, a full relapse that maybe we don't see that patient come back, or maybe that relapse is the highest rate of opioid overdose deaths occur during that phase of stabilization and no opioids, and then we get back in. So relapse prevention is an extremely part, and those key elements include understanding relapse as a process, not as an isolated event. Really focusing on developing those new coping skills for like high-risk situations and identifying what a high-risk situation is. Making different lifestyle changes, right? How do we make those lifestyle changes now to reduce the need for illicit substances later? Increase your participation in those healthy, sober activities. Understanding and addressing social pressures. Developing a more supportive relapse prevention network. I think that's really important. And that really starts with you as the clinician and the clinical team, and then it starts to develop an outreach from there. And very important to develop methods around coping with negative emotional states and those cognitive distortions. I think that's really important during relapse prevention. And then develop a plan to interrupt a slip or a relapse. And so what's your plan if you do relapse? How do you interrupt that? How do you stop that? And then obviously really focus on that, those warning signs, whether that's an internal or an external trigger, those warning signs, kind of those key elements to prevent relapse from ever even occurring. So those are really important to engage and to work with the patient on. I think that wraps up our presentation for our second series. Again, I do not like PowerPoints, and so I am wide open for questions and engagement at this point. If anybody like to chat in a little more detail.
Thank you, Josh. That was awesome. Really informational for me. I enjoyed it. Does anyone have any questions for Josh? You can type them into the Q&A box or to the chat if you have any questions. Yeah, but that was great. Thank you. And then someone else asked, this was very helpful. Will the PowerPoint be available for us to review? That's not, are we able to send it to?
I'm good with that. Yeah. Again,
Okay.
my biggest focus, guys, is education, training, knowledge. I want everybody to have as much education as they can. And so I'm 100% okay with that PowerPoint being shared with whoever.
So we can share the PowerPoint with you, and we are also recording this because we have a few health centers who want their whole team to review these and learn from them. So we are recording them, and we can send those out to you as well. How can we access the recordings? So we'll be putting them on the AACHC YouTube page, but I can definitely send you all an email as long as there's no glitch with the recording and we can get it uploaded today. I can send that to you later today so that you can share them with your staff. And we'll continue the next two as well. I believe next week we're going to be talking about special populations and considerations there.
Yeah, next week's that'll be, it's not necessarily maybe as long as a presentation, but it's very important. So, we'll be going into some of those one-off situations that you get as a clinician. Your pregnant patient that comes in, right? You have a patient that has been on pain management for extended period of time, and then there's this like conversion, right? It goes from like pain management to like, oh, now I'm struggling. So we're going to talk about some of those areas a little bit and what you can do and how do you address that and work with it. Even population differences, right? So it's like your kids, like your adolescents, this is real. And so it's we can't pretend that it doesn't exist. So we're really dealing with, kids 10 years old addicted to opioids. And so we've got to be able to have strategies in place and work with folks on that side of things as well. So we'll get into the special population a little bit, and then we'll wrap up with peer support and talking about peer support program and how important it is for successful outcomes.
So next week, I feel like is going to be a really important one. So we hope that you all can attend, but if not, I'll be sure that if you're on the attendee list today, that we send that out after it's uploaded. We always like when you can attend, just because then you can engage in conversation, ask questions on the spot. Does anyone else have any other questions for Josh?
Janelle always mentions, and I'll make it kind of a pitch here as well. And I mention, we're continuing to provide needs assessments for different organizations. And then as those needs assessments are completed, I continue to be a support for those individual networks. I see we've got some Valleywise folks on there, and I was just saying, gosh, it was like maybe 2 or 3 weeks ago, I got a call from a Valleywise employee, one of their physicians that was starting an induction, and was like, hey, it's been a while because we worked with Valleywise, gosh, it was about a year ago. I remember you having this lecture. I remember you talking about this. Can we walk through this induction? Absolutely. Take that phone call, walk through the induction, make sure that patient's getting the care that they need. So, we do want to be that level of support and be available to make sure that those patients are getting the care that they need. So, any of the health centers that haven't had a needs assessment or are interested in that, make sure you guys are reaching out to Janelle. Those are things that we can set up, we can get going. And we would be happy to assist wherever possible.
We do have some in the works, probably some of you that are attending today. But yeah, I just kind of want to follow what Josh said. The Valleywise needs assessment, I feel, was even more than a year ago. And the fact that, you know, they know that they can reach out to Josh for support, that's one of the huge benefits of doing it, because he already knows the structure of the health center and how they're doing things and stuff like that. So he's there for support if you guys need it, even after this process is over. So there are tons of benefits, as I've probably mentioned many times in webinars before. It can help you to see, you know, what components of your program are working well if you already offer some of these services, what's going well, what could we help assist with to improve the program, and what the next step would be to assist these patients. So it can really help provide like a clear picture for your organization in terms of what's next for substance use disorder services. So unless there's any other questions, we'll go ahead and end a few minutes early. And then just a reminder to join us back next week on Wednesday, same time, 9 to 10 for the special populations webinar. Thanks, everyone.